Let's hear personal experience of Dr. Gopal Pillai with this Brolucizumab. Please be on the line so that we can have some discussion. Yeah.
Thank you very much, sir. As we know, fluid always plays a significant role in neovascular AMD and DME. And what we have to now know is how rapidly we are able to reduce the fluid and how long are we able to control the recurrence of fluid. So all the guidelines for retreatment decisions are based on presence or absence or occurrence of new fluid, and persistent fluid will definitely lead to lower visual gains, and CSFT fluctuations may be associated with poor vision gains in diabetic macular edema. So what we are looking at is for faster action and longer duration. So we know about the single chain antibody fragment and how this is a much more smaller fragment, and so what happens is that the molar concentration that this offers is like about 12 times higher than aflibercept. This is a much more smaller molecule. The clinical dose is 6 milligram what we have, and the relative number of molecules is like much higher than other anti-VEGF agents. Like aflibercept, it's 1 as compared to 11.2, about 12 in the brolucizumab group. So brolucizumab has the smallest molecule, which means it can probably penetrate much more deeper in choroids, etc., and designated especially for ophthalmic use and potentially addresses these unmet needs. And preclinical studies suggested that smaller molecular size of brolucizumab may facilitate better retinal penetration. So that is again another factor. High ocular concentrations are balanced by rapid systemic clearance. That is also very important. So if you're putting a higher dose of the drug and it crosses into the systemic circulation and causes more problems, then that becomes a non-starter. Whereas here, even though the eye concentration is very high, the rapid systemic clearance makes it much more safer in terms of systemic approaches. And each 6 milligram delivers a 12-fold higher molar dose than aflibercept of the same volume, so which has the potential to deliver durable efficacy. Brolucizumab binds with high affinity to the VEGF-A isoforms. So in Crystal and Kite, we can see that by 100 weeks, there are significant patients, there's a significant difference between aflibercept 2 milligram versus brolucizumab 6 milligrams. So by the percentage of patients with intraretinal fluid or subretinal fluid was about 41 versus 54, and percent of patients achieving a CSFT less than 280 was again 63 and 51, which makes it significantly different. So visual gains were comparable to aflibercept. In fact, that was a comparative study like that. In both studies, patients treated with brolucizumab received fewer injections, like 11 injections by 100 weeks, that's 2 years, as compared to 15 injections of aflibercept in 2 years. Overall safety profile was consistent with the 52 weeks data, so which means that brolucizumab as well as aflibercept in terms of diabetic macular edema, like Anirudh was telling, the intraocular inflammations were much lesser. Now the post hoc analysis of Crystal and Kite, the time to dry, so that was significant. So you can see the area under the curve also. So you can see that brolucizumab dries much more rapidly. By week 52, it was 37 against 32% in the Crystal, 40 against 31%, so about 10% difference. By week 100, it became 83 upon 70 or 80 upon 57, which means there was about 15% difference in the rapidity of drying. And time to achieve CSFT, that also you can see by week 32, 50 against 35, and by week 52, it's about 58 against 46. Much more rapidly the brolucizumab was able to dry. So time to sustained dryness, which means that now we are looking more towards duration. can we have, with 2 consecutive visits without injections? So at least 3 months, can we push without injections? That also, brolucizumab against aflibercept, you could see that there was a huge difference, like 78% against 76%, 47 against 32, 50 against 34, about 12 to 15% difference time to sustain dryness, and also to achieve a CSFT of less than 280. So we all know fluid plays an important role. Brolucizumab offers a unique structure and higher molar concentration. Efficacy has been proven through the crystal and kite studies, and safety is also done. Comparative BCVA gain and numerically more fluid reduction, and fewer number of injections compared to aflibercept, faster and sustained drying. So this is one patient who had come to me with diabetic macular edema, who had both eyes injected ranibizumab biosimilar over a period of time, and then over a period of time, he was lost to follow-up and came back like this. And on the right eye, you had this particular picture. You had a hard exudate which is abutting on the center of the fovea, which with brolucizumab completely dissolved. Whereas the other eye of the patient had significant edema like this. And you can see with each injection of brolucizumab how things are changing slowly, slowly, slowly. And then at this point of time, cataract had come, and that had to be removed. Now, this is another patient who had been treated on ranibizumab biosimilar again with no good response after 4 injections. And then you can see that this was the time when he was being treated with ranibizumab. And in fact, you can see that at some point of time there was a little delay in treatment here, and that is why probably the edema went up here. And you can see that once we started treatment with brolucizumab, this was probably a patient who has, so for the first time, we reached complete resolution of fluid. And then the injections, you can see that slowly, slowly, it is improving, and at some point of time, that is completely reaching resolution. And the number of injections that you will require and the dryness and the rapidity of reduction is much easier and faster with brolucizumab. In my practice, I have used brolucizumab more extensively in wet AMD than in diabetic macular edema. There is a learning experience which is coming in, and with more and more confidence, I would be moving more and more into the diabetic macular edema. Thank you very much.
Thanks, Gopal, for this. I was expecting more cases. Actually, you showed only 2 patients, so we were wanting more real-world scenario, because, as you rightly said, the purpose of all these CMAs is to learn from each other's presentation, and seeing cases gives a lot of confidence. So, because Anirudh said that if in contrast to AMD, DME is much more responsive and less chance of inflammation also. So maybe I think the next meeting you should present data of brolucizumab in DME also.
Yeah.
So I just have one query. Like the younger patients should have more inflammation. I haven't gone into the data, so I can't say. But we know from that younger patients should have, and that's how in the gene therapy for DME as well as AMD, they had to stop the treatment for DME because of the severe inflammation leading to phthisis. So I'm just wondering why it's different for brolucizumab.
Anirudh.
I can answer that. I think that is probably related to the cumulative effect. And so if the patient grows older, maybe that patient has been exposed to more biological agents in the body, and that's why that may be a cumulative response. And younger patients may not have that. So that could be one factor identified in that particular paper.
But younger patients generally are more reactive. No? More reactive means any injury, any wound, anywhere, the response is more like keloid formation rather than an older patient. But I agree, older patients, it's more likely that they must have been exposed to all these agents more than the younger patients. So I think cause may not be, these are all theories which, we agree with each other.
I think one of the take-home messages from me, from the 2 talks from Aniruddha and Gopal, is seeing that the hard exudates, you've shown these nice cases where the hard exudates are disappearing. Till now, I will change tomorrow. Till now, if I saw hard exudates there, I would give Ozurdex. And then with the losing heart, if there's a subfoveal hard exudate, then I'm almost thinking I've lost the game. I have to do something, I give the steroid. But maybe I'll go back and use the Pagenax now in those patients.
Yeah, and we haven't lost the game. Actually, I have been giving in subfoveal as well, and they do improve a lot. After a few injections, after a year, the vision is very different. They may have started with 4/60, and now you are ending up with 636 or 624. So it improves. Don't give up.
Malika,
I
if
could
this
not
happens-
go.
Sorry,
but,
if this
but,
happens after a year, because you see,
Yeah,
if
it
it's
takes time.
either
It takes
it's
time.
a effect of the drug or it's the effect of disease modulation.
No, drug. The disease was always there for years. When you intervene, then you see the change. And you
No,
see
what
the
I'm saying is
exudate going away.
once we start treating a disease with injections,
Yeah.
patients generally becomes afraid also, and he starts his control better compared with prior experience. So if 1 year or maybe more than that is being taken to have that effect, then if the drug effect has to come, because the pharmacokinetic data shows that the peak effect comes say in 8
3
weeks
months,
or whatever, then it should come early.
Yeah, it starts coming. I'm just talking of the final vision. But you start seeing the exudate disappearing and vision improving immediately in 2-3 months.
Gopal, Gopal, I wanted to ask you, like, what I was looking at, like, I shifted a few of my patients on Ozurdex because they developed glaucoma, recalcitrant glaucoma, which was due to, last stage diabetic disease also. So can you extend to 3 months, like, because in those patients whom I switched from Ozurdex to Pagenax, I could manage to maintain them for 3 months with a single dose of Pagenax. Have you seen that in your chronic patients? Not treatment-naive patients, I'm saying.
Generally, we will move to Ozurdex when they are not responsive so well to the anti-VEGF. So the anti-VEGF, what I meant was the first group, in the sense ranibizumab or bevacizumab or aflibercept. So if that is not acting, then only we usually move to Ozurdex in diabetic macular edema, or if you want to reduce the number of injections. Now Brolucizumab has come in as like 3 monthly or 4 monthly you can inject. So definitely it will be a good strategy, like Anirudh said, because we do not have to subject these patients to glaucoma or cataract. So that's a very good thing. And now second thing is, in a patient with Ozurdex, if I have a glaucoma, if you do a trabeculectomy, then you can continue the patient on Ozurdex for no problems.
Yeah, that's acceptable. So Anirudh, Gopal first line and last slide also was drying. And this fluid theory, propagated by, a lot of people for last year or maybe two. So they say if some fluid is tolerable, SRF is tolerable, even sometimes they will go to the extent of saying that this may be associated with better visual acuity also. So I fail to understand that how come, fluid is tolerable. I personally feel that fluid not getting, it's a defeat of the drug rather than saying that fluid is tolerable.
You're right, sir. In DME, especially, you cannot tolerate fluid in DME. Absolutely, no, not even intraretinal or subretinal. In the context of AMD, in the fluid study, they did say that the fluid in the subretinal space may be rather protective. But not all of us follow that because there is no real evidence to say that subretinal or sub-RP fluid is actually protective. So in general, I think we all give up, and because you give up, you try to latch on to something, and so you say that this might be actually protective. If the agent is probably ineffective, that's when you can kind of give up on the treatment and just say, it is protective.
Absolutely.
No, I would like to say, sir, that in the real world it is completely different from the clinical trial scenario, because
Yes.
initially when a treatment-naive diabetic macular edema comes to us, we will definitely try to keep him fluid free. Yeah. But after 6 months, 9 months, if the number of injections are mounting, then he and we will have a discussion together to keep the little bit of edema with lesser number of injections. Maybe in 1 year his vision may drop 1 line, but that is okay considering, the discussion will come out to say that he is okay with 4 injections instead of 8
so
injections.
Gopal, my reaction to this is exhaustion by patient as well as the doctor.
So,
This
this
exhaustion.
finance comes in and science takes a back seat, is what I've seen.
Correct.
Let's be frank.
Correct.
Finance takes the first seat after patient is exhausted, and his funds basically is what I feel. That's what it decides. the treatment.
Logistics and finances, I think. So it's
And about the OCT biomarkers, you said, if there are, or color photograph biomarkers, if there are a lot of hard exudates, today your drug of choice will be, Anirudh?
So if it's a non-favorable OCT, hard exudates, the sketic changes that even Dr. Gopal sir, he showed OCT with a lot of sketic changes, I would go for Brolucizumab.
First line.
first line, and because I would like to give the benefit initially, rather than give Eylea or something else. Maybe they work.
So a
I'm
lot
not
of
saying
people
they
say,
don't.
that in diabetics, if you delay treatment by a couple of months, heavens are not going to fall, and you control the metabolic status first, and then. So how do you react? Suppose a patient of hard exudates, lot of hard exudates, and he has poor metabolic control. You still go ahead and do Brolucizumab.
This is a little, I'll answer it in two ways. So if there are lots of hard exudates, of course I will do fluorescein, I might even do laser, because I still do focal laser, sometimes micropulse laser. So it just depends on the amount of fluid. If the fluid is not much, maybe I'll do laser with systemic control, delay injections. But if there is fluid to begin with, center involving, then there is no point of delaying the injections, you have to inject. So this is how I usually do it.
Aniruddha, I loved yours. Yeah, sorry.
I think the point Anirudh is making, the point I also wanted to make, is that yes, people talk about waiting for metabolic control. If the patient has good vision, if the patient comes to you with 6'9", yes, please wait for metabolic control. If the patient already is 6'12", 6'18", then both go hand in hand. I will give them the injection and try and get the physician to do the metabolic.
A word
I'm
of
not going to
caution
wait
there, because some of these patients, when you send for metabolic control, they come back after 3 months with loss of metabolic control and loss of vision also.
Yeah, I agree. Why deny treatment in this exciting times when we have agents to reduce it?
I would
And
want to ask
One more thing.
metabolic and control can go hand in hand parallel.
No, one more thing, sir. The diabetic doctors, the endocrinologists, they have changed their management of systemic control. Now we have newer agents, long-lasting insulins. We have weight loss agents. We have bariatric surgeries. In the context of all of this, I think it becomes very difficult to depend on factors like HbA1c, to depend on fasting sugar, for example, because these are so variable. In a patient who's had bariatric surgery, now there is evidence to say that HbA1c values have to be considered separately. So with so much going on the endocrinology side, I don't think we can solely depend on systemic control for 3 months with a center involving edema. It's very difficult.
I want to bring in another
agree with
aspect,
laser.
sir.
I agree with laser part only when it's laserable. If it is center
Yes.
involving DME,
Then no point.
Yeah.
Sir, may I bring in another aspect? Now, with Brolucizumab telling that the molar concentration is like 11 times higher than the other drugs, and now Aflibercept bringing in the 8 milligram, which makes the molar concentration higher, is it that the higher molar concentration of these drugs are actually making it more efficacious than the primary generation of anti-VEGFs and increasing the duration? Now, for example, if we are having higher concentration of ranibizumab, for example, would it make a difference?
You're asking me, sir? Should I answer that?
Yeah.
No, yeah.
So I think what Eylea has done is something very simple. They have basically increased molar concentration to increase durability. And so that is slightly different from the molecular structure of Brolucizumab itself. In Brolucizumab, the difference is in the structure itself, which is giving it probably higher efficacy, higher durability, less clearance. So I think there is some basic fundamental difference between the two. I'm not sure if that will work for ranibizumab by just increasing the molar concentration, because it depends on the affinity of the binding. So there are lots of things involved, and of course the safety and other parameters. I think ranibizumab has already hit the hilt. It is the maximum possible. So far we're waiting for Eylea. Maybe let's see how it goes.
Lalit, can I bring in another aspect? We keep coming back to economics in the previous session and in this session. And the one thing I like about Pagenax, I'll go out on a limb, is that it does not have a patient support program. Why? Patient support programs are good because they reduce the cost. But one, they distort clinical practice. If I've given 3 Eylea and I want to change, the patient will say, "Sir, 4th to free milna tha na." So and I'm seeing no effect. I say, why am I giving this 4th?
So your point is that there should be no PSPs.
That is one point, sir. That is the first point. The second point is the PSPs are administered by a third party, not by Novartis, not by Roche, not by Bayer. Some third party has the data of my patients. I'm strictly against that. I don't like that. They're even asking for the patient's Aadhaar cards. And data is strength today. somebody who has a database of all my patients can do whatever with it.
So Somdas is
I
very
don't really
emotional,
like it.
emotional
So-
about
so-
secrecy of data, but
Yeah,
we are talking
so-
pure science as this
So
moment.
you give me a drug at an average lower price is much better to me than give me 1 plus 1 plus 2 plus 1 plus 5 plus 7, whatever.
So notice people, we will request that instead of giving us PSP, you reduce the price slightly so as to be competitive. So that is better than. Anirudh, do you have any patient or any data or observation or comment regarding the patients who are DME on Ozurdex and you have shifted to Brolucizumab?
Yes, I have patients on other agents, including steroids, shifted on Brolucizumab, simply because after 2 or 3 Ozurdex, I myself become slightly uncomfortable, especially in phakic patients, how long to pursue with steroids. So I have shifted them, and in fact successfully. Another aspect, I think, vitrectomized eyes. In vitrectomized eyes, previously I used to use only Ozurdex, but I think Brolucizumab works very long. It lasts long. Third thing, in patients with systemic diseases like strokes or cardiovascular events, I think with ranibizumab and aflibercept, there was, although the concern has been junked by systematic reviews, but faricimab, even brolucizumab, these agents could be tried.
So you mean to say that patient who has a recent history of MI is 0.3 milligram Razumab or ranibizumab safer or Brolucizumab is safer? Patient who has a recent MI.
Actually, sir, the data shows that both can be used, but the systematic reviews, meta-analysis say that both can be used. But it's personal preference. I use either brolucizumab or faricimab.
Yes,
One
Malika.
point, a point I'm trying to make is we don't have the port delivery system with ranibizumab.
PDS,
But actually, if we had that, that is extending the intervals to 10 months easily. So, and now it has been revamped. There was some defect in the device.
There was. You see, they went out of this.
Now
thing
it is
for-
again back.
Yeah.
And now the patients are very happy with the 10-month intervals that they are getting. So we don't have access to that. But ranibizumab can also be extended. There was I think Dr. Gopal had brought up the point, whether it's just molar concentration which is making the difference. So we can, in fact, even with ranibizumab, extend the interval, but we don't have the PDS.
I'll just give one perspective on PDS. The PDS is running into a couple of more issues, which is it is converting a medical case into a surgical case because you need to do vitrectomy there to implant that particular device. And so we are running into insurance issues because you have to open the pack, you have to take the patient into OR, do a vitrectomy, implant the device itself. And then this, although it can be refilled in the clinic, but implanting it has to be done in the OR. So I think that is something that the company is still struggling with. They would like all the procedures to be video recorded. So like Dr. Sir was saying about the patient confidentiality and, so I think these are some issues that the PDS still has to overcome.
So how much vitrectomy is advocated? Because PDS, you see, apart from that incisional issues and vitrectomy issues,
Yes.
so 8 months advantage vis-a-vis,
Even 10 months, 12
it has to be, loading
Yes.
can be done, refill can be done in OPD, but generally
Yes.
first procedure is a surgical case then.
Yes, so it has. So the company says a vitreoretinal surgeon has to do the implant, and they say that it has to be done keeping all the vitrectomy instruments available in case a full vitrectomy is required. They say that localized vitrectomy has to be done in that particular area.
Okay, any other comment or question by anyone? So I think we can wind up this session by making a couple of comments which should, remove those myths people have. Somnath, you were talking something about economics. If you have increased durability, I have prepared a couple of slides about economics, which I was talking in the last session. I don't know how many people were there, but these longer agents, because of the increased duration, ultimately, if you calculate yearly cost, they come out to be cheaper than even ranibizumab or even biosimilars or even Eylea.
Absolutely, sir. I have personally been using Brolucizumab for DME before it was licensed for DME. So it was licensed for AMD, but not for DME at that
So
stage.
for you,
and I have a lot of patients who are on 4-monthly treatment now. Not all, maybe about 1/3 or something. Not all. Some are on 3 monthly, some are on more often. But but a lot of patients can be even managed on 4 monthly. So for them, it is a very cost-effective drug. For them, it is cheaper than biosimilar actually.
The last point is about the visual gain. You see, we talked about fewer injections with Brolucizumab. We talked about more drying. Gopal said faster drying without any compromise of visual acuity. What about visual is similar to aflibercept, or do we have, because does more drying translate into better visual acuity or not?
It's comparable, sir. As per the clinical trial evidence, they say it's comparable to aflibercept, and this is at
real world
comparable. There is no study which says that any agent is superior to the other in terms of visual acuity.
So I think if
the trial, there's no study like Aniruddha says, but if you look at the graphs, or the ILIA graphs have the sawtooth thing, which we've always seen. The Brolucizumab graphs do not have the sawtooth thing.
Yeah.
To me, I can't prove it, but that is a better thing. There's something going up and down is better than something, is not as good as something which remains stable.
100%, I think, Anirudh, I agree with what Somda is saying, is that
Yes.
you see any retina where, we are talking fluid amongst the photoreceptors. So you have some fluid coming, then going, some coming, some then going.
That's not
That may have a detrimental effect on the long-term function. So even though statistical data by studies or even real world do not show a greater benefit, but more drying, a sustained drying will definitely, I think, have a better long-term prognosis.
Absolutely agree, sir.
So I think with this, if all of you agree, we can conclude this session by saying that all the myths about surrounding the use of Brolucizumab need revisit, and the eye opener from your talk, Anirudh, was that patients who have hard exudates, they may be preferred treated with Brolucizumab, with the advantage of fewer injections, more drying, faster drying, without compromise of visual acuity. If there are any further questions, we would love to take. So thanks, Anirudh, for joining us, and
Thank you.
maybe
Thank you, sir.
we'll
Thank you.
meet physically also sometimes. Thanks.